Hello, everyone. Thank you for joining us today for our webinar entitled Stage for Success, Medicaid Promoting Interoperability Stage 3 in 2020. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting the presentation slides and a recording of today's webinar on our website, www.mceda.org. Also, the presentation slides are currently available for download in the Handouts section of your GoToWebinar interface. Today, Bruce will provide you with an overview of the Medicaid Promoting Interoperability Program, reviewing core program rules, eligibility criteria, and 2020 program requirements. From there, Bruce will take a deeper dive into the Stage 3 objectives and measures, discussing important issues to be aware of this program year, and review the state requirements for electronic clinical quality measure reporting. Lastly, he will provide some links to important program resources, and with any time left, he will address questions posed by the attendees. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everybody for joining me today. We will go through the agenda that's on your screen now that Liz just touched on, and with any luck, I won't talk for the entire time, and I'll actually be able to answer some questions live, which if any of you attend my webinars, you know that that isn't always the case. There is a wealth of information that I can share, and I'll try to couch it so that I can fit it into into the time we have here. So let's dive right in. We'll start off by talking about some of the kind of overall program basics. So one thing is the name change. I know a lot of you have gotten used to it now, but this used to be called the EHR Incentive Program. A couple of years ago, it got changed to the Medicaid Promoting Interoperability. Causes a lot of confusion out there because there are really three different programs that use the term promoting interoperability. There's still a Medicare hospital program, and then the quality payment program within the MIPS track there has the promoting interoperability performance category. That is a separate program. It has nothing to do with the Medicaid promoting interoperability program. In a lot of ways, it's still easier to consider this as meaningful use, which was the street name of the EHR incentive programs back in the day. So I still find that to be a useful way to draw that distinction between the MIPS PI promoting interoperability performance category and the meaningful use program. So Medicaid PI is still going to continue for a couple more years. So we have 2020 and 2021 as the final program year. There are still significant incentives to be had, $8,500 per provider, but you had to start participation in this program no later than the 2016 program year. So as long as you either achieved meaningful use or at the very least claimed the very first incentive, they called it AIU, or Adopt, Implement, and Upgrade. As long as you did that by the 2016 program year and have not claimed all 6 of those incentives, you still have a couple more years to get any remaining incentives. If you're not sure if your clinicians had started that participation or where they're at in the program, if they still have incentives to claim, if you grab the deck, that start population that you see on the screen right there, the hyperlink will take you to the state of Michigan's Who's Been Paid list, and you can look up your clinicians there. This is a voluntary program. There are no penalties for not participating. There are, if you find yourself in the MIPS program, if you find your participation might be mandatory there and you have to participate or you get penalized. That is not the case in this program. It is completely voluntary. If you do not participate, you just don't claim any of those incentives that are left. So there is still $17,000 in incentives to be had per clinician, however. And you do need to be on your 2015 version of your EHR. That is mandatory now. I know Most of you have been upgraded to 2015. Some of you are still struggling. There have been a widespread vendor issues that continue to plague us now in early 2020. So I know not all of you have upgraded yet, but you do have to ensure that you are upgraded no later than October 3rd of this year, because that would be the first day of the last 90-day reporting period. And you must be using 2015 technology on day 1 of your reporting period, and then the version has to be certified by the last day. No changes in the program eligibility provider types. We don't anticipate any changes as we kind of ride out the last couple of years. So if you are a Michigan Medicaid provider and you are a physician, a dentist, optometrist, nurse practitioner, certified nurse midwife, or a physician assistant practicing in what's called a PA-led SQHC or PA-led RHC, you are eligible to participate in this program. So once you determine you are an eligible provider type, the next annual requirement is ensuring that you have adequate Medicaid patient volume. So to be eligible to the program, each year that you participate, you have to demonstrate that a minimum 30% of your patients have Medicaid. That is a little bit lower for pediatricians. They can qualify at a slightly lower 20% patient volume, but just note that if you choose to qualify at 20% versus 30% as a pediatrician, you're only going to receive 2/3 of the incentive payment instead. And unfortunately, mid-level providers do not meet the program's definition of a pediatrician. So eligibility reporting period, where you're kind of demonstrate that you've got that adequate Medicaid patient volume, is a continuous 90-day reporting period. There are 2 different time frames that you can use. It is your choice on which of them to use to look for that continuous 90-day reporting period. We have the prior 12 months option, which is defined as the prior 365 days from the date of attestation. And then we have prior calendar year, which is defined as the calendar year prior to the program year to which you are participating. So for example, when you're attesting to program year 2020, the prior calendar year would be any continuous 90 days in calendar year 2019. Although of particular note, this is something that plagues attesters every single year. These options, once the attestation period opens, creates what's called a dead zone of unusable eligibility dates. For example, oftentimes, and it's a little bit different this year, and I'll touch on that and some additional issues that creates, usually the attestation period opens up in the first 3 months of the following year. So if you were going to log in to attest a little over a year from now for 2019, for the 2020 program year, so if you were attesting on March 21st of 2021, then the eligibility dates between January 1st of 2020 and March 20th of 2020 are now, they're not in prior 12 months nor prior calendar year. So be aware of that. This creates some havoc every attestation period. A lot of Medicaid patients end up coming in for their annuals in Q1 each year. And so it is traditional for clinicians to try and use Q1 as their eligibility reporting period. But depending on when you log in to attest for that program year, you may find that you can't use Q1, or it's difficult to use Q1 because the date range you're trying to use ends up being in what we call that dead zone of unusable eligibility dates. There are 2 different ways that you can qualify your clinicians. You can look at individual provider data. So each one of your clinicians is finding their own 90-day reporting period in one of those 2 options where they get that 30% Medicaid patient volume. You can also do what's called the group proxy option, where you're using group encounter data. So it is a single 90-day period that measures all of your clinicians all at once. And so one set of numerators and denominators can qualify the entire group all at once. This is a great way if you have clinicians that are maybe a little bit under the 30% on their own, you've got others that are over the 30%. By using that group proxy option, you can often get all of your clinicians qualified in the program all at once. But we have one issue with that I'll touch on the next slide after this one. So part of those Medicaid PI requirements then for 2020 is stage 3. It was mandatory in 2019. That is the same in 2020, and it will be the same for next year as well. We've got 8 objectives within the stage 3 requirements, and there are 20 associated measures. And I'm going to talk about all of those as we get deeper into the slide deck. Just like we've had every other year, it is a minimum 90-day reporting period on those measures. It can be anywhere from 90 to 365 days. You may find that by extending your reporting period beyond the 90, you can perform better against the measure thresholds. So don't necessarily just limit yourself to a 90-day reporting period. You may find that by extending that to 100 or 150 or even 365 days, you might be able to achieve those measure thresholds. And that can and often is different from the eligibility reporting period. So those are 2 different reporting periods. They don't have to be, but most often we see clinicians reporting with different eligibility reporting periods than they do their objectives and measures reporting period. You do also, again, have to report on 6 clinically relevant electronic clinical quality measures. Last year, they started to match these requirements to the MIPS program. So just like in that program, one of them must be an outcome measure. And if no applicable outcome measure is available to you, you can report on at least 1 high priority measure. And if no clinically relevant outcome or high priority measures are available, you can report on any 6 relevant ECQMs. This is new for us, however, in 2020. In prior years, it has been a full 365 days of reporting for your CQMs. For this year and for next year, it is a minimum 90-day reporting period. So that is going to create some changes for us. What that's really going to do is allow clinicians to start to attest to 2020 throughout the year. In previous years, we had to wait for the calendar year to turn before you could attest to that program year. Now, because the ECQM reporting period is also a minimum 90-day reporting period, that's going to kind of change things for us here. Note that that change is just for the Medicaid PI program, though. The MIPS quality performance period category is still 365 days. So there is a mandate that within this program, those ECQMs must be reported electronically, and on slide 36, we'll discuss that mandate. And so with that change then, the attestation period is going to open much earlier this year. Again, in previous years, we would have had to wait until January of 2021 to attest for the 2020 program year. Because we now have ECQMs at 90 days as well, that means you guys get to attest a lot sooner. You can attest as soon as you meet those program requirements this year. So the state of Michigan is set to open 2020 attestation period on April 2nd. It is subject to change just based on when they can close out the 2019 attestation period. But as of right now, we have it set at that you could actually log in to EMIP, to CHAMPS, on April 2nd of this year and get your 2020 attestation in, because that is more than 90 days into the year. But with this change, it has created a potential issue with your eligibility reporting period that I want to call your attention to. So this resource is actually also a PDF that you can download right now in the handout section, right alongside today's slides. But I pulled it into the slide too to kind of walk you through the issue we have here. So, or the potential issue, I should say. So I just described the eligibility reporting period, what those 2 options are, the prior 12 months and the prior calendar year. That information is reflected here again. Then we have this potential issue that creates. So using the group proxy option, that group encounter data, and the prior 12 months option for the eligibility reporting period could be problematic for some of you. So if you follow along with the colors here, the purple text makes reference to the purple up here, and so on and so forth. So in this example above, we have a group of 2 clinicians that have chosen the group encounter option for eligibility, and they're using the prior 12 months option and an eligibility date range of April 3rd of 2019 through 7/2/19. So the first clinician attests to their 90 days of meaningful use on 4/2/20, the first day that they possibly could. They're going to log in and get 2020 taken care of. So they're able to do that with no issues. They're using that prior 12 months, which is captured within the previous 12 months from the date of attestation. Everything works just fine there, no issues. Later in the year, EP2 attempts to attest to his or her 90 days of meaningful use on September 1st, using the group eligibility data that was previously entered by the first clinician. So with an attestation date of September 1st, the eligibility date range is no longer within prior 12 months for this EP. Well, this isn't necessarily going to happen for some of you, but I just want to make you aware that you don't get yourselves into trouble downstream when your second, third, and fourth clinician goes to log in and attest to meaningful use. So the solution here is clinicians using the group encounter data for proving eligibility for this year and next year, because we're going to see this again next year, should use the prior calendar year option and choose a 90-day eligibility reporting period in 2019 for program year 2020, or in 2020 for program year 2021, to ensure that the chosen date range for the eligibility is applicable to all the clinicians in the group, regardless of when they attest. Alternatively, you could just avoid this potential pitfall by using individual clinician eligibility data versus the group encounter option. So either just stick to individual encounters. If you are going to use group encounters, and especially if you know your clinicians are going to attest at different times throughout the year, don't use previous 12 months. Use prior calendar year option. Otherwise, you could get yourself into the issue we have reflected here. All right, we are going to take a deep dive into the stage 3 objectives and measures. Some of these I'll touch on very quickly because kind of nothing has changed over the years, and y'all are used to some of these objectives and measures. Some of them we're going to take a little bit deeper dive into as well. I have all 8 of the objectives here. These are all hyperlinked to the specification sheets for 2020 as well. And with that, we're going to dive into objective 1. So objective 1 is one of the ones I'll go through pretty quickly. Nothing has changed. This is your security risk analysis. You have to either conduct or at least update your SRA each and every year. It has to happen during the calendar year. It doesn't have to take place within your 90-day reporting period. It just has to happen within the calendar year. And be careful in terms of documentation or audit guidance. Although the yes/no objectives are going to appear on your program dashboards, really your EHR has no idea whether the SRA was completed or not. Oftentimes, some of those yes/no measures will default to say yes. That doesn't mean you actually conducted it, and that's not going to be enough in terms of audit either. So if you get audited, the state is going to have you prove that you have not only completed your security risk analysis, but that you have a corrective action plan that also includes some updates as identified issues are addressed. Objective 2, electronic prescribing or ERX. Again, no changes here at all from last year to this year. For more than 60% of the permissible prescriptions, you're going to query them for a drug formulary and transmit them electronically using your EHR. Be wary of those thresholds. We don't see this as often as we did in the past, but some of the EHRs will tell you you are meeting the measure at 60%. The threshold is actually more than 60%, so it has to be anything above 60% to meet any of these thresholds. So just be wary of that. Make sure your EHR is calculating that correctly. There are exclusions here. Again, we don't see a lot of people needing to take these exclusions anymore. Most of you have ERX kind of up and running, and you're using it as your primary form of writing prescriptions. If you do claim the exclusion, however, just make sure that you have some documentation to back that up. CDS, clinical decision support. There are 2 measures within this objective. You have to meet the thresholds for each of them in order to meet objective 3. So again, no changes at all from prior years. In measure 1, you're going to implement 5 CDS rules related to 4 or more of your ECQMs. And in measure 2, you have to ensure that you have enabled and implemented the functionality for drug-drug and drug allergy interaction checks for the entire PI reporting period. In measure 1, you have to ensure that these are turned on day 1 of your reporting period as well. These CDS rules cannot be turned on during the 90 days. They have to be turned on day 1 of your 90-day reporting period. There is an exclusion for measure 2 if you have fewer than 100 med orders during your reporting period. And this is one to be careful of in terms of documentation and audit guidance. Again, just because your dashboard says you have things enabled, that's not going to be enough in terms of an audit. You need to have some additional documentation to prove that these objectives were turned on for the full 90 days. There's a lot of different ways to prove that. It just depends on what the CDS rule is. You can take print screens, written confirmation from the system administrator. There's a lot of different ways that I have reflected here on the slide, but just make sure that you've got something saved so that up to 6 years from now, if you get audited for this program year, you're going to be able to prove to the state that your CDS rules were turned on for the full 90-day reporting period. Objective 4, CPOE, computerized provider order entry. So in this objective, again, no changes at all. For medication, lab, and diagnostic imaging orders, you're just ensuring that the proper staff are the ones entering those orders. They can be the EP themselves, a credentialed medical assistant, or medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant. Credentialed does not mean certified. Your certified MAs can certainly do CPOE as well, but they do not have to be certified to do CPOE. They just have to be credentialed. Credentialed just means that they have graduated from an accredited MA school. We have several here in the area, such as Ross and Everett, a lot of great schools that are credentialing MAs to be out there in the world, acting as MAs. As long as they have a diploma or a degree or whatever the school calls it, that's going to be enough to allow them to do CPOE. There are 3 measures within this. You have to satisfy all 3 of them to meet the objective. And no changes in these thresholds. Measure 1 it has more than 60% of med orders. Measure 2 is more than 60% of lab orders. Measure 3 has more than 60% of radiology orders. You have to meet the objectives for all 3. Otherwise, you are not a meaningful user. In the documentation guidance, I just want to draw your attention to make sure you have that documentation of the credentials for any staff members that are doing CPOE, in particular those MAs. Make sure that you have a copy of their diploma from their MA school to show that they were allowed to do CPOE. Objective 5, patient electronic access to health information. In this objective, the clinician provides patients with timely access to their health information and patient-specific education. So we've got 2 measures within this objective, and again, you have to meet the thresholds for both of the measures in order to meet this objective. In measure 1, more than 80% of all unique patients seen by the clinician, the patient is provided timely access to view online, download, and transmit his or her health information, and the provider ensures that the patient's health information is available for the patient to access using any application of their choice that is configured to meet the technical standards of the Application Programming Interface, or API. So 2 different ways. Timely access applies to both of them, and I will note here that timely access within this program, within Medicaid PI, is defined as within 48 hours of the information being available to the clinician. It is different in the MIPS PI, and we've seen this create some issues for some of you that are participating in both programs. MIPS PI defines timely access as 4 business days. We've got a much tighter window here under this program. It is within 48 hours. That is not 48 business hours either. That is within 48 hours. So you could find yourself in trouble just by not getting things posted over the weekend even. Again, note that timely access applies to that API access as well. You have to ensure that you are providing all of this data through the patient portal, as well as allowing those patients to connect to your API as well. Measure 2, the EP must use clinically relevant information from their EHR to identify patient-specific education resources and provide electronic access to those materials for more than 35% of the patients seen during the PI reporting period. I will note here, as I highlighted, it is electronic access. This was a change that happened in stage 3. In prior versions of meaningful use, we were able to provide paper versions of those of that education and get credit for it. You can still give the patient paper versions of the education, but you're not going to get numerator credit for it here. You have to be pushing those education resources to the patient electronically to get access. And here we had to go onto a second page. Again, there are a couple of exclusions. However, one of them is not going to apply here in Michigan. That second one that talks about high-speed internet access, no counties in Michigan qualify for this, so I put a strike through on that just to kind of signify that it doesn't really apply to anyone here in Michigan. And really, the first one sort of doesn't apply either. If you try to claim that you have no office visits during the PI reporting period, the state of Michigan is going to push back on that. Basically, if you don't have office visits, that means you're not seeing patients face-to-face, and if you're not seeing patients face-to-face, you're not going to be able to be a meaningful user. So if you try to claim that exclusion, expect a battle from the state. I would not recommend it. You are probably going to lose. So really, there are no exclusions to this. And I've got some documentation for that audit guidance as well. Again, you want to make sure that you're grabbing some print screens. You want to have everything you need here to be able to prove that all 4 of those functionalities, the view, download, transmit, and API access, were available to your patients for the full 90-day reporting period. Objective 6, coordination of care through patient engagement. So here we have 3 measures in this one, and you have to meet the thresholds for at least 2 of them to meet the objective. So I often get asked, what does it mean then if you claim exclusions here? So you have to meet 2 out of 3. So you could actually fail the threshold, fail to meet the threshold on 1 of the 3, meet the threshold on the other 2, and you'd pass the objective. You could also claim an exclusion for a measure, but if you claim 1 exclusion, you have to meet the thresholds on the other 2. You can no longer fail one and still meet the objective. If you claim 2 exclusions, again, you have to meet that threshold on that 3rd one. And you could claim exclusions on all 3 of the measures and kind of take a pass on the objective as well. But just note that if you claim an exclusion out of 1 of the 3, you must meet the thresholds on the other 2 or qualify for the exclusions on those 2 as well. Okay, so let's go through all 3 of these objectives, or all 3 of the measures here, I mean. So measure 1 is more than 5% of all the patients seen by the EP are actively engaged with the electronic health record, and they are using that patient portal access. So you have to ensure that you're providing that patient portal access to them, but then you have to have, again, as we've seen in prior years, you have to ensure some of them are using it. It doesn't matter how they interface with it, as long as they are viewing, downloading, transmit, or accessing it through that API technology that you have available. As long as more than 5% of them are accessing their information electronically, you're going to meet that measure. Measure 2 is the secure messaging portion. So again, as we had last year as well, more than 5% of those unique patients seen by the clinician during the PI reporting period, you're going to send a secure message to them using your EHR. You can also respond to a secure message sent by the patient, and that would also count towards it. So any outbound message from you to the patient is going to go towards that more than 5% threshold. Measure 3 is kind of a weird one. I talked about this last year as well. We continue to see some kind of wonky things happen with Measure 3. This is the patient-generated health data or data from a non-clinical setting gets incorporated into the EHR for more than 5% of all unique patients seen during the reporting period. The EHRs are really struggling to program this one correctly. I've relinked you to the specification sheet here. If you are intending to meet the threshold on Measure 3, I highly recommend grabbing that spec sheet and reading through it so that you really understand what CMS means by patient-generated health data or data from a non-clinical setting. There are some weird rules built into it as well in terms of when you can get that data from the patient and have it count towards the numerator. This is one area we see the EHRs really struggling to program their systems correctly, and it's very understandable in this case. The intent of this measure is for you to engage with your patients outside of the office visit. So you're not supposed to be getting numerator credit for this measure if you are receiving that patient-generated health data within that regular office appointment. It's supposed to be something that the patient sends to you through the patient portal or mails into you or faxes to you or however they get it to you outside of that patient visit. That's when you're supposed to be getting numerator credit for it. We have seen, however, the EHR is really struggling there, which I can understand why. The EHR doesn't really a lot of them don't really care when that patient generated health data gets incorporated. So be careful with that one. Grab that spec sheet, make sure that your EHR is calculating things correctly. Again, there are exclusions here, the same two we saw on the previous one, but just be careful. If you claim that you have no office visits during the PI reporting period, the state's probably going to push back and say you can't be a meaningful user if that's the case. And then that second one with broadband access does not apply to any counties in Michigan, so I crossed it out. Be careful with the documentation needed for the audit as well here. In some ways, some of the data can just be pulled from your meaningful use dashboard, but Measure 2, especially, you're going to have to grab some print screens again to somehow denote or prove that the bidirectional messaging was enabled. Print screens are often a way to do it. Just make sure that you're redacting any patient information from them. And yeah, so again, depending on if you're claiming those exclusions or whatever you're doing in these measures, if you're going to meet those thresholds or claim those exclusions, make sure that you've got some documentation built into your audit file so that up to 6 years from now, you don't find yourself in trouble. The next couple of objectives, I'm going to take a little bit deeper dive because there's some additional things you need to be aware of. Objective 7, health information exchange. This is one that continues to be very difficult to achieve. It is no different this year. It's not getting any easier. The EHRs are really struggling with this one as well. But again, this year there are 3 measures. And again, just like on the previous one, you have to meet the thresholds for at least 2 of them. So again, this is where we see a lot of exclusions come into play with clinicians still. And again, you have to attest to all 3 of them. So you're going to enter something for all 3 of them. You could actually fail to meet the threshold on one of them and still meet the objective as long as you're passing on the other 2. And again, if you claim an exclusion for one of the measures, that means you have to meet the threshold on the other 2. You could claim 2 exclusions, and then you have to meet that last threshold, or you could claim all 3 exclusions and kind of take a pass on this objective and still be a meaningful user as well. So in Measure 1, as we have been working with really through all of the years of meaningful use, this is the sending of summaries of care documents to the next clinician of care. So for any outgoing transitions of care or referrals, you have to create a summary of care and electronically send it to that next provider of care for more than 50% of those patients. Measure 2 looks at the other side of it. It's the incoming. In Measure 2, for more than 40% of transitions or referrals received and patient encounters in which the provider has never before encountered the patient, the clinician incorporates into the EHR an electronic summary of care document. And I'll talk about Measure 2 a little bit deeper as well in just a moment. Then we have Measure 3, which is clinical information reconciliation. This one has a high bar, but it's for more than 80% of transitions or referrals received and new patient encounters. You have to perform clinical information reconciliation. At a minimum, you have to reconcile medications, medication allergies, and the current problem list. Again, there are exclusions for each of them. The second one I have again taken off, the broadband one, since no counties in Michigan qualify for that. But for Measure 1, you can exclude from this measure if you transfer a patient to another setting or refer a patient to another provider fewer than 100 times during your reporting period. Measure 2, you can exclude from this measure if any EP for whom the total of transitions or referrals received and patient encounters in which the provider has never before encountered the patient is fewer than 100 during the PI reporting period. And I'll talk about another step you can take to delete patients from the denominator in Measure 2 as well. So I'll touch on that in just a moment. And then Measure 3 has that same exclusion as Measure 2 for any EP for whom the total of transitions or referrals received and new patient encounters is fewer than 100. You could take a pass on that one as well. So in Measure 2, you have the ability, and this is unique to this measure, you have the ability to remove patients from the denominator after you do your due diligence to locate a summary of care record. So for any of your incoming referrals and for any brand new patients that you've never before seen, you have to take steps to try and find that summary of care record. You have to request it. If you request it, you've deemed that it is unavailable, you can then exclude that patient from your denominator. So you are not harmed by the fact that you could not incorporate a summary of care because you couldn't find one. You got to look for one first. So you do that by first requesting that summary of care document be sent to you by that sending clinician. And then you also have to query at least one external source via HIE functionality. And if you do that and you still don't locate a summary of care record through those two steps, by asking the sending clinician for it and querying an external source, if you cannot find that summary of care document, you can remove that patient from the denominator calculation. That way you are not harmed in your performance on this particular measure. Querying through that one external source, some of you are working with EHRs that have this ability built right in. I think Epic does it automatically. ECW, you have to opt in and pay for that service. Some of the other EHRs are doing the same thing. They are starting to build this functionality right in. You might have to pay additionally for it within your EHR, but if you do, you can kind of query this external database of summary of care documents that the EHRs are tapping into to locate that summary of care. Michigan Medicaid PI is working with MyHIN, the Michigan Health Information Network. It kind of oversees a lot of what we do here in terms of health information exchange in the state of Michigan. They are launching something called Medicaid, which is going to be a free service that's going to allow you to query an external source for a summary of care on your patients. It is in the process of launching right now. Stay tuned for further details from us as we learn more about it and what that onboarding process looks like. But if you're interested now, you can click on that link on the slide. We'll take you to the MyHIN website, and there's some information on Mitigate as well as some contact information, and they can start to get you set up with this. The state of Michigan has worked it out with MyHIN to offer this to you as a free service as well, which is a great benefit. A little bit of additional information on this objective. For Measure 2, that's again that incorporating that incoming summary of care. It cannot be considered incorporated if it is discarded without that reconciliation of clinical information or if it is stored in a manner that is not accessible to the EP within the EHR. So once you get that summary of care, it's not enough to just get it. You have to then perform the reconciliation of that clinical information on it, and then you have to ensure that you store that somewhere within your EHR. CMS is not strictly defining what incorporate means. They're kind of leaving that up to you and your technology to decide, but just make sure that you are, as long as it's saved somewhere, as long as a copy is accessible, as long as that data that you've received on that summary of care is accessible within your EHR, that is defined as incorporate. For measure 3, the process may include both automated and manual reconciliation to allow the EP to work with both electronic data and directly with the patient to reconcile their health information. So for measure 3, you don't have to get that electronic summary of care to conduct that clinical reconciliation of that information. Do it however you can, whether it's electronic, whether the patient is patient-reported information, just get that information reconciled so that you can get over that more than 80% threshold on that measure. If for measure 3, no update is necessary, the process of reconciliation may consist of simply verifying that fact. So make sure that you get that numerator credit for attempting to do that the reconciliation, but not needing to. Oftentimes there's a little checkbox within your EHR. Click that off to say that there was nothing to reconcile, and then you would get that numerator credit for the measure. Non-medical staff can also conduct that reconciliation under the direction of the EP, as long as the EP or another credentialed staff member is responsible and accountable for that information. One last piece here on objective 7, in terms of documentation guidance. Again, we've got some good guidance here for you across measures 1 and measure 2. Just documenting, especially if you're going to be claiming the exclusions, or for measure 1, you're also supposed to have what's called reasonable certainty of receipt by the receiving provider. So you'll need to be able to prove that you know that not only did you send that summary of care on, that the receiving provider received it as well. That's reasonable certainty of receipt. So you could have, depending on how you're sending it, you should be able to garner that information. You might even be a redacted print screen of that outgoing message that indicates that it was sent rather than failed or undeliverable as well. Objective 8, public health and clinical data exchange. I'm going to go through each of these measures as well to make sure that you understand what it means to be actively engaged with each of the different measures or the different registries that are out there. Within this objective, you have to be actively engaged with at least 2 registries. You can use the same measure twice. For instance, we work with some clinicians that practice on the Michigan-Ohio border, and they might be actively engaged with MICR, Michigan's immunization registry, as well as Ohio's. That means they could attest to measure 1 twice, and they'd be able to meet that objective that way. So we're going to walk through each of these 5 measures. I just talked about immunization registry reporting. We have syndromic surveillance reporting, electronic case reporting, public health registry reporting, and clinical data registry reporting. So I'm going to unpack each of those 5 as well and talk about some things to watch out for if you are going to be attesting to one of those 5 measures. But first, we'll define what it means to be actively engaged. There are 3 different options for active engagement. Any one of these options means you are actively engaged. So you don't have to be in option 3, production. That's of course best when you're sending that live electronic data to whatever the applicable registry is. But you could also just complete the registration with the registry within the first 60 days of your reporting period, and that would be option 1 of active engagement. That is just fine. You would still be meeting the measure if you hit option 1. But just note that you have to make sure that you are registered for it within the first 60 days of your EHR reporting period. Otherwise, you cannot claim option 1. Option 1 is the only one that has that stipulation with that has to be completed within 60 days. If you are in validation and testing, which means you are somewhere in the process of onboarding, you're you're working with the registry and your EHR to get to that point of being in production where you're sending live data, that means you're in option 2, testing and validation. That is also actively engaged. So any one of these 3 options means active engagement. So let's dive into each of those 5 measures now. Immunization registry reporting. You're going to attest that you are actively engaged to not only submit, but also receive immunization forecasts from MICR here in Michigan. There are 3 exclusions. I've crossed out 2 of them because they just don't apply here in Michigan. So the only exclusion you could take from this measure is if you do not administer any immunizations. So in Michigan, we have MICR, the Michigan Care Improvement Registry. You do have to be actively engaged for the bidirectional connection. MICR calls it QBP, or query by parameter. So unidirectional active engagement, which is what we had under stage 1 and stage 2 of meaningful use, that no longer meets program requirements. Stage 3 requires that bidirectional interface to be at least actively engaged for that bidirectional interface. So, and MICR also, as of this year, requires you to be in production with the unidirectional feed. They call it XVU, I'm sorry, VXU, prior to accepting your registration for QBP. Some of you have not been able to get that unidirectional feed up and running in prior years. The state of Michigan gave you a little leeway last year to still engage for QBP. That is not the case in 2020. If you are not live in production with VXU in 2020, you are not going to be allowed to actively engage for QBP, and you will not be able to attest to meeting this measure. So that is a minor change here in 2020. You must be in production for the unidirectional feed in order to be actively engaged for QBP. And if you're not actively engaged for QBP, you are not meeting this measure. So to begin that QBP process, send an email to the address on your screen right now. You're going to hear back from MICR with some instructions. Just follow those instructions that you receive in reply, and you can become actively engaged for QBP. Syndromic surveillance, not a lot to say here because the vast majority of Michigan clinicians do not qualify for this measure, because MSSS, the Michigan Syndromic Surveillance System, will only accept data from hospital ERs and urgent care locations. So if you're not a hospital ER or an urgent care location, you cannot engage with MSSS and for this and then attest to this particular measure. Also note that I know some primary care offices, after the regular hours, they turn into an after hours, an urgent care-like location. That does not count as an urgent care. It has to be an actual urgent care location in order for MSSS to work with you. Electronic case reporting, you're going to be attesting yes to being an active engagement. Here, again, we do have an exclusion. A lot of clinicians would qualify for the exclusion on this one as well. We do have the Michigan Disease Surveillance System, MDSS, and there are there's some additional qualifier here too, and I have it reflected here under the criteria for electronic case reporting. There's the data originating from eligible hospitals and eligible professionals, and then the capability to submit electronic case reports into standard format. The translation of those 2 bullets is that if your EHR is not certified for electronic case reporting, the EP cannot use this measure. So if you try to engage with MDSS, the very first question you're going to get is, what's your EHR? That team is going to look at the Chapel website, which is hyperlinked here. That's what the certified link is. That's going to take you to the Chapel website. That is the CMS or the ONC's laundry list of all certified products. If your EHR is not certified for electronic case reporting, MDSS is going to reject your engagement with them. In which case, even if you are treating or diagnosing reportable diseases, which they are collecting, you could claim the exclusion there. So you're not stuck between a rock and a hard place. So if your EHR is not certified for electronic case reporting, you can claim that exclusion. So before I get onto the other ones, I'll pause here and talk about what used to be known as specialized registries. In prior versions of meaningful use, we had the term specialized registry. That is not a stage 3 measure, but don't fret. All of those specialized registries that you've used in the past, or the majority of them anyway, are going to map to one of the other 2 measures. It's either going to be a public health registry or a clinical data registry. It is a public health registry if it is administered by or on behalf of a local, state, territorial, or national public health agency. So think governmental entity. If it is run by the state of Michigan, it is a public health registry. If it is run by the CDC, it is a public health registry. All of the other ones, the ones that are non-governmental entities, all of those registries, and there are a lot of them out there, are clinical data registries. So what used to be called a specialized registry has been broken into these 2 buckets. So they're all, for the most part, going to map back to being a PHR or a CDR. So we'll talk about the PHR reporting next. Again, we do have some exclusions here, but there are actually very few clinicians who can claim an exclusion from public health registry reporting. I've completely crossed out 2 of them, of those exclusions, because they absolutely do not count here in Michigan. And the only one that isn't, the clinician practices in a jurisdiction, very few clinicians are going to be able to claim that exclusion as well. And I'll talk about why in just a moment. In Michigan, we have quite a few public health registry options for you. MAPS, the Michigan Automated Prescription System, is a very popular one right now. The state of Michigan is funding all of those integration costs. So I highly recommend working with that one, with MAPS. If you do any kind of prescribing at all, you have the Michigan Cancer Surveillance Program, the Birth Defects Registry, the Birth Registry, Newborn Screening. There is also Michigan's Dental Registry, otherwise known as MITRE. However, you cannot use MITRE in the Medicaid PI program this year. This was the same last year as well, because it does not currently use a valid specified standard for data transmission. That is a new requirement under stage 3, that all of these registries have to be using what they deem a specified standard. MITRE does not use one of those currently. We hope that they will at some point. So MITRE cannot be used under Medicaid PI, but it is still okay to use under MIPS program. So, and then similar to electronic case reporting, if your EHR is not certified for cancer reporting, you're not going to be able to engage with the Michigan Cancer Surveillance Program. That team, and again, just like on the electronic case reporting, one of the first questions they're going to ask you if you try to engage with them is, what's your EHR? They're going to check the Chapel list, make sure that it's certified for the cancer reporting. If it's not, they're going to reject your active engagement. And then nationally, we have the CDC National Healthcare Surveys Registry. This is a very popular one. It is national in jurisdiction, and they accept data from every clinician type out there. And so that is why I am warning you against claiming an exclusion from the public health registry reporting, because almost everybody is going to qualify for the CDC's registry. And therefore, you cannot claim that you practice in a jurisdiction for which no PHA is capable of accepting your data, because the CDC accepts data from everybody, except, this is a change for 2020, and listen up if you are using the CDC's National Healthcare Surveys Registry. As of this year, 2020, the CDC is going to require that your EHR is certified to the PI criterion of transmission to public health agencies. I've got the specific regulation listed there. You can go to the Chapel website and pull up your EHR to see. The vast majority of the EHRs out there are certified to this standard, but there are still a few out there, and even some pretty popular ones, that are not certified to this particular standard. They could get certified this year and then all is well, but if your EHR is not certified to the transmission to public health agencies healthcare surveys standard, the CDC is going to shut down your active engagement, and you would not be able to claim that active engagement with the CDC registry. So again, that is new for 2020. It is totally fine in 2019 if you're not certified to it, but your EHR must be certified to that standard in 2020 and 2021. Otherwise, the CDC is going to say you are not actively engaged with them any longer. Clinical data registry reporting. Again, we are looking at the other side, those other specialized registries. These are the registries that are managed by the American Board of Medical Medicine, of our family medicine. There's a lot of these registries out there. You can note that the jurisdiction is often national with these CDRs, so be careful if you're going to claim that you practice in a jurisdiction that doesn't have a CDR. A lot of these clinical data registries their jurisdiction is national, so they're going to encompass you. So again, we have the PRIME registry from the American Board of Family Medicine. I got a link there to the National Institutes of Health list of registries. That is not a comprehensive list, but it gives you a whole bunch of other options out there in terms of CDRs. To be valid for use, the registry has to publicly declare readiness to accept your data within at least 6 months prior to the start of the program performance year. They have to be able to support the registration, onboarding, and production processes, and they have to be able to provide documentation of evidence of that active engagement. If they do not do all of those three things, you do not have to engage with them. So just be aware of that as well. There is this potential PI stage 3 issue with these former specialized registries. That thing I was just talking about with the Michigan Dental Registry, MITRE, that registry is falling victim to this particular statute as well. Again, this does not apply to the MIPS program, but does apply to Medicaid PI measures. So this is pulled right from the specification sheet. It kind of talks about, and I've got the translation there, because these are often written in a way that nobody can understand. The translation for Measure 4 with this regulation is, if the registry is a public health registry, does not use a standardized method or language for the transmission of data, and you did not attest to being in active engagement option 3 production in a prior program year, it cannot be used in the Medicaid PI program to meet stage 3 requirements. And then for Measure 5, if the registry is a clinical data registry and doesn't use a standardized method or language for the transmission of data, it also cannot be used. So I've got this next slide that kind of helps you make sense of it. This is something we worked with the state of Michigan to develop. So this is the methodology the state of Michigan is using to validate these registries. At the very top, they're going to ask who administers this registry. If it's a governmental entity, is it using specified standards used for the data transmission? If the answer is yes, it's all good. Has the EP achieved production status in a prior program year? If the answer is no, it can't be used. If the answer is yes, it can. Other side of this, it's a non-governmental entity, so it's those CDRs. It's much cleaner. They just look on whether specified standards are used for that data transmission. If the answer is yes, all is well. You can become actively engaged and use it under stage 3. If the answer is no, then you cannot. And in terms of documentation, you've got to be able to prove that you're actively engaged with whatever registries you're going to attest to. Just make sure that you are getting some documentation from that registry where they acknowledge your active engagement. If it is one of the state-sponsored registries, you can access HISTR, the Michigan Health System Testing Repository, at the bottom of your screen there with the link. That is the site you've probably been using to even engage with the registry as well. That is also where you can kind of monitor your status as well as print those active engagement letters for the registries, for those state-sponsored ones. Again, that is just for the state-sponsored ones. If you're engaging with a CDR, you're going to have to contact that registry. If you're working with the CDC, they're going to provide that letter to you as well. Here is a list of all of the state-sponsored registries with links to each of them if you are interested in onboarding with them. And so what must program participants do prior to claiming a public health measure exclusion? So at a minimum, You have to determine if the registry being offered is in your jurisdiction, and be careful, some of them are national depending on the registry, and are relevant to the provider's scope of practice. So you can look at the prior slide for those state options. One national level example is the CDC registry. If clinically relevant and you're technologically capable of connecting with them, you have to achieve active engagement with that registry. Next step is you can look at the medical societies to which your providers are affiliated and see if they endorse or sponsor a valid registry for use in this program. Again, if clinically relevant and you're technologically capable of connecting with them, you have to achieve active engagement with that registry. If through steps 1 and 2, you cannot become actively engaged, or you can't find a registry that makes sense for you, then you can claim an exclusion for one or perhaps both of those required measures. But just note that claiming an exclusion in this program does not count towards meeting the public health objective, unless you can exclude from so many of those measures that there are fewer than 2 to which you can become actively engaged. So an exclusion for a measure does not count towards the total of 2 measures. Instead, in order to meet this objective, an EP needs to meet 2 of the total number of measures available to them. If the EP qualifies for multiple exclusions and the remaining number of available measures is less than 2, the EP can meet the objective by meeting all of the remaining available measures and claiming the applicable exclusions. Lastly, we'll talk about that the ECQM data submission requirement. There is this program called SCIMR, CQMRR, the Clinical Quality Measure Reporting and Repository Service. It's kind of a mouthful, but we pronounce it SCIMR. It is another MyHIN service brought to you by the Michigan Health Information Network. So SCIMR submission kind of validates that data format of your electronic clinical quality measures and then passes that file on to the CHAMPS or EMIP system so that it's there when you go to a test. It phases out the manual quality measure submission process and moves us towards the ultimate goal of report once capability. A lot of different programs out there are all leveraging these clinical quality measures. We are working towards a system where you can submit the data one time to one entity, SCIMR, and then that program would parse it out to all of the different programs to which it applies. We're not there yet. The only thing SCIMR is doing is helping you through your meaningful use attestation, but hopefully down the road, it's going to be able to submit that quality data to the MIPS program for you as well, or to some of the payer level quality programs as well. So we're not there yet, but that's where we're moving towards. To submit that 2020 CQM data, you're going to need to get what's called a QRDA3 file from your EHR. It can be either individual or group level. You're going to submit that through the SCIMR system. SCIMR then is going to validate that data, and they're going to submit it on your behalf to the state of Michigan there. So it'll be there when you go to a test. So the link there to register, and you can also test your files at that site as well. And just like in last year, the state of Michigan wants you to at least attempt to submit electronically. If you cannot do it for a variety of different reasons, you can request Enable Web, or what we also call Break the Glass approval. If you send an email to the email address on your screen there and explain why the clinician or group is requesting that manual CQM data entry, give them a little information, talk about any troubleshooting that you've done, and the state will enable you to manually enter your CQM data again, as long as you have at least attempted to get it to them electronically. And just like last year, the state doesn't necessarily want you to be paying money for this QRDA3 file. A lot of the EHRs are charging you for that file. If you're using one of those EHRs that is charging you, you do not have to pay for it to submit for the meaningful use program. That alone would be enough to get manual data entry approval as well. Okay, that's it for really the slides. I've got a wealth of great resources here for you. A lot of this information is reflected on the slides that we just went through. That very first resource are some measure tip sheets that we developed last year that are still relevant to stage 3 in 2020 as well. Again, they just go through all of the different objectives and give you some little tips and tricks for meeting those thresholds. The eligible professionals, the EP guide, this one right here is also probably one of the most important resources. If you are not familiar with the Meaningful Use program and how to work with the state of Michigan, grab the EP guide. That is a wealth of information in there as well. And then we've got some great information here in terms of the skimmer process, including the registration and onboarding guide, which will kind of walk you through how to use that system to submit your electronic clinical quality measures. All right, with that, I actually have a few minutes to answer some questions for a change. So if you have any questions for me, please submit them to the GoToWebinar interface right now in the questions box, and I'll get to some questions. If you think of anything afterward, you've got my email address right here. You've got you can also get to the MCEDA site. The state of Michigan is still funding us to be out there helping you. So for next to nothing, you can get one of my colleagues working right with you in your office to work through EHR issues. A lot of vendor issues are still plaguing clinicians out there. If you need help with workflow development and just really anything related to this program, including helping you attest when it comes time to get that information submitted to the state for a very, very, very low cost. The state of Michigan is picking up 96% of that cost. We can be out there helping you as well. So give us a call. We'd be happy to assist you. We've got a handful of questions. Let me take a look at what came in as I was talking, and we'll get these questions answered. Again, please send me questions. All right, Jeanette, great question. So if you attest for 2020 as early as 4/2/20, would your SRA need to be done within the first quarter of 2020? No, it is okay. Great question. I'm glad you brought that up. It is okay for your SRA in 2020 to be completed after your 90-day reporting period. It just has to be done within the calendar year. So if you were to log in and attest on your very first day, as Jeanette asked here, on April 2nd, when the state opens up 2020 attestations, when you get to that objective, you're really just going to be attesting to the fact that you're going to be conducting your SRA this calendar year. So it's sort of the honor system there. The state is trusting that you are going to conduct that SRA before the calendar year is done. And if you get audited, they will be looking for that, for that information. So great question. Nope, your SRA can be done outside of that reporting period, and it can be done even after you attest to it. You just have to make sure that it is done within this calendar year, and you will be just fine. Good question. Next question. For the bidirectional interface, can't we just use the HISTR letter from the state? That is all they ever ask for. Yes, that is, if you can generate a 2020 letter that shows that you are actively engaged with MICR for their bidirectional interface, that is all you're going to need as proof that you did what you needed to do to be able to attest to measure 1, the immunization registry measure. So yes, get that letter. But again, I just caution you, the prior year's letters are not enough. Again, you have to be actively engaged for QBP and in 2020. Otherwise, you are not going to be actively engaged with MICR. And you have to be in production status with the unidirectional messaging, what was really the standard in prior years, in order to even engage with MICR for QBP. We got a little bit of a pass. The state kind of bent the rules a little bit in 2019, allowing some of those clinicians, as long as you put your foot in the door to get QBP, you were able to still attest to the fact that you were actively engaged with MICR, even though you hadn't yet achieved unidirectional production. That is not the case in 2020. You have to ensure that you get past whatever it is that's stopping you from being in production for that unidirectional feed. Otherwise, you will not be able to claim active engagement for QBP in 2020. Right. Looks like I have one question left. National Healthcare Survey does not give their letters until 12/31/20. What proof can we give to the state if we attest in April through November if they cannot give us letters? That is a fine question. Ooh, that's a conundrum. So you're not going to be able to get the letter from the CDC for 2020 until after the program year, yet you're going to have to prove that you're actively engaged. That's a good question. We might have to take that one to the state and see what they want to do. I would suspect it would again just be the honor system, much like with your SRA. If you can get any kind of communication from the CDC at all, email, correspondence, anything of the sort, that would be enough as well. But that is a very good question. I'm going to take that one to the state next week. I'm meeting with them in Lansing next week, and I'm going to add that to the list. So Randy, I will circle back to you, but I suspect the state will be willing to work with you, especially if you've been actively engaged with them in the past. There's no reason why you would have lost your active engagement unless you're working with an EHR that's not certified to that standard. So certainly if we will work with the state as well to make sure that they are aware that there's a problem there, that you're not going to be able to get that active engagement letter probably till the end of the year from the CDC. So I suspect the state will just kind of take that on the honor system, and then they would pick it up in an audit if you said you were active engaged with the CDC, but then when it gets audited, you could not prove that you were via that letter. So great question, Randy. I appreciate that one. I will take that to the state and just confirm with you. All right. With that, it looks like I'm giving you a whopping 3 minutes of your day back. I have no other questions, but again, we are always here for questions. Please, 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 if you are struggling in this program at all, if you've got any questions for us, we want to help you. Ping me. I'm happy to help. As I know a lot of you are well aware of, I get inundated with questions, and I love hearing from all of you. So with that, thank you so much for joining me today. I look forward to seeing you on future broadcasts. Have a great afternoon.